So good evening, ladies and gentlemen. So the comorbidities of the case have already been previously elucidated. So I will now focus on the seizures of the patient. So if you look at the pattern of the seizures of the patient, which started at 3 months old, which was then very responsive to the medication which was given, which was phenobarbital, and the patient was actually asymptomatic for more than a year until at around 2.5 years of age when the seizures recurred, and this time it progressed until the patient was already 3.5 years of age. So the seizures were characterized as generalized, but it was not elucidated what kind of generalized seizures the patient manifested, whether this was clonic, tonic-clonic, absence, whether the typical or the atypical type, the myoclonic absence, and atonic or astatic generalized type of seizure. It is very important for us to fully characterize the type of the seizure because this will have a major bearing on the type of medication that we will give to our patients, such as the following, okay? So for instance, there is for generalized tonic-clonic seizures, for instance, there is an advantage of giving valproate over the other medications as to the control of that particular seizure. In absence, there is a typical advantage of ethosuximide as well as valproate in the control of seizures, as well as for myoclonic and myoclonic absence, wherein valproate as well as levetiracetam for myoclonic seizures could also be given. And for atonic seizures, valproate is also at an advantage, as well as non-pharmacologic maneuvers such as the ketogenic diet. And as you can see, for almost all types of generalized seizures, valproate actually has an advantage in adequate seizure control. And let us also take into consideration that there are some anti-epileptic drugs which could actually worsen the seizure, as evidenced in the study by Chavez and Sander. And this is not actually a complete list, but you could always refer to their study. And as you can see in this table, there are medications, particularly lamotrigine, which could aggravate the myoclonic seizure, as well as for oxcarbazepine, which could also worsen the tonic-clonic seizure of the patient. So let us all bear this in mind when given anti-epileptic drugs for our patients. So what happened to the patient? So why was phenobarbital initially effective for more than a year in this patient, and then suddenly it became ineffective and actually worsened the seizures? So there are possible scenarios in this case. Probably the phenobarbital was not up-titrated sooner to maintain a therapeutic dose of 3 to 5 milligrams per kilogram per day. Or there is such a thing as what we call a paradoxical effect of the drug, wherein the phenobarbital exerts an inverse pharmacodynamic effect on the patient. And most commonly, according to the study by Peruca, there are 3 scenarios wherein a particular medication is not ineffective in a particular patient. And 1, probably there is an incorrect diagnosis of the seizure type or the syndromic form. 2, there is lack of knowledge about certain drugs that are contraindicated in particular types of epilepsies, such as what I mentioned a while ago, and prescription of excessive drug dosages and drug combinations in a particular patient. So most probably, either one or several of these particular scenarios contributed to the worsening of the seizures of this particular patient who initially responded to phenobarbital. So how will I now manage, if I were the attending neurologist of this patient, how will now I manage the patient's worsening seizures? First of all, we have to go back to redefine the seizure type. What is the characterization of the seizure, which could give us a clue as to narrow down which of the anti-epileptic drugs would be best for this particular patient as far as seizure control. And EEG, we have to do the EEG because it was not mentioned in the protocol that the EEG was actually done. And let us all remember that the EEG is actually the most valuable tool in the evaluation of seizures and the epilepsies. And it will also define if the patient belongs to a particular epilepsy syndrome. And drug withdrawal is also part of the management, considering that phenobarbital is no longer effective or even contributing to the worsening of these particular seizures. Later on, we have to highly consider gradually withdrawing the drug. So, in choosing the appropriate anti-epileptic drug for this patient, we have to depend on several factors, and these are equally important. Again, let me emphasize that the seizure type, defining the seizure type is of primary importance, as well as determining if this particular patient falls under a specific epilepsy syndrome. We also have to define patient characteristics, such as in this case, the patient has several comorbidities, as what was mentioned in the earlier. And of course, the drug profile and the accessibility to the drug. Even if for example, if the drug is very effective, if it is not accessible in the locality, so they will not be able to comply with the medication. And of course, economic factors. Even if the drug is very effective, if the family could not financially sustain the medication, so it will be futile in the control of seizures of this patient. Going back to the drug profile, we also have to take into consideration if the patient has had any adverse effects such as hypersensitivity or allergy, or could not tolerate the side effects of this particular drug. That is also one of the considerations in choosing the appropriate anti-epileptic drug. So now what will I plan for this patient? We have to go back to the history, okay? Do another physical examination and neurologic exam. All these three are very important, and this should not be overemphasized. It will help us define and redefine the seizure type, the type of epilepsy of this patient, and of course, if the patient falls into a particular epilepsy syndrome. We also have to redefine the seizure type, if this is really a generalized type of seizure, or if the patient manifests with different types of seizures, maybe a combination of generalized as well as focal seizures, which again will influence the kind of medication that we will give our patient. It will also tell us if the patient warrants that the patient would be maintained under monotherapy, or perhaps the patient would benefit from polypharmacy. And of course, we have to do an EEG, okay? Again, just like what I've said, it will define a lot of information pertinent to the patient, and it will refine our choice of anti-epileptic drug. And then once we have done all these, then we will start an appropriate AED depending on the factors I previously mentioned. And then we will go slow, start with a very low dose, and then titrate very slowly until we observe an effect on the patient. And then once the seizures are already controlled using the new drug, then I would slowly taper off now the phenobarbital. So again, that would be the plan for this patient, and I would welcome any questions that you will ask later on in the forum. Thank you.